Hello, and welcome. If you're a nurse who cares for surgical cancer patients, then this is for you. We're going to dive into something that is absolutely critical in their post-op care: how we prevent venous thromboembolism, or VTE. All right, let's get right into it.
I want to start with just one thing, a number, 20, as in 20 times.
So what is that? Well, that's the increased risk your patient has of developing a potentially deadly blood clot after they've had cancer surgery. Compared to just about anyone else. It's a really staggering number, and it highlights exactly why our attention to this is so unbelievably important.
So let's really frame this the right way. We're not just talking about another post-op complication here. No, we are talking about a preventable killer. See that word? Preventable. That's the key to all of this. It means that we as nurses have the power to change the outcome. VTE, and you know this covers both DVTs and PEs, it's a constant threat, for sure, but it's one we can actually do something about.
And this chart, wow, it just lays it all out, doesn't it? Look at that jump. So a cancer diagnosis by itself, that bumps the risk up about 7 times. But then you add major surgery into the mix, the risk just explodes to that 20-fold increase we started with. This isn't just a small step up, it's a giant leap. So the big question is, why? Why is it so high?
What is causing this perfect storm of clotting risk? To really get it, we need to go back to a classic concept that perfectly explains what's happening inside our patients.
So just think for a second. What's the common thread here? You've got the patient's cancer, you've got the surgery they just had, and you've got their post-op recovery. What ties all of those things together physiologically?
The answer is Virchow's triad. This is the absolute foundation for understanding why blood clots form in the first place.
And this right here, this is the whole story. Your surgical oncology patient is the living, breathing, textbook definition of this triad. First, the cancer itself puts their body in this hypercoagulable state. It basically makes their blood stickier. Second, the surgery, no matter how neat and tidy, causes some injury to the blood vessel walls. And third, they're not moving much during or after the procedure, right? So the blood pools, it becomes static. You've got all 3 risk factors happening at the exact same time. It is the perfect recipe for a DVT or a PE.
Okay, so we know the risk is huge. We know why the risk is huge. So what's our most powerful tool to fight back? Well, that brings us to low molecular weight heparin, or LMWH.
And you don't have to take my word for it. The major clinical guidelines are crystal clear on this. LMWH isn't just one of many options. It's considered the first line, the standard of care for these patients. This is established, evidence-based best practice.
And there are so many good reasons why it's the gold standard. Major studies have proven it's just more effective. Its anticoagulant effect is way more predictable than older heparins, which is a massive win for safety. It also has a much, much lower risk of causing that dreaded complication, HIT. And super important for this patient group, it has fewer interactions with chemo drugs, and you can give a fixed dose without needing constant blood tests. It's just a smarter, safer, and more effective tool for the job.
But, as we all know, it's never as simple as just giving a shot. Every single time we prepare that syringe, we're making a critical clinical judgment call.
This is the tightrope we walk every single day. On one side, we have this life-saving mission to prevent a clot, but on the other, we have the very real risk of causing a bleed, which is, of course, the #1 side effect of any anticoagulant. And our job is to navigate that balance perfectly for our patient, every shift.
Think of this as your mental checklist before you give a dose. You have to know the difference between absolute contraindications, the hard stops, like an active bleed or a history of HIT, and the relative ones. Relative contraindications aren't to know, they're a, hang on, let's think about this. Things like poor kidney function, which might mean we need to adjust the dose, or recent brain surgery, where we have to wait a specific amount of time. It's not just about ticking boxes, it's about critical thinking right at the bedside.
And part of that critical thinking is knowing the patient's specific diagnosis. We know now that certain types of cancer, like hematological cancers, lung, prostate, and colorectal, they come with a higher baseline risk of bleeding to begin with. So for a patient with one of these, our risk-benefit calculation needs to be even more careful.
All right, so we've got the right drug and we know how to weigh the risks. But you know what? None of that matters if the dose gets missed. And that brings us to our last and honestly our most important point. When it comes to VTE prevention, every single dose counts.
This is what happens on a physiological level, and it happens fast. When a dose is missed, that protective effect wears off. And that underlying prothrombotic state from the cancer, it comes roaring back, creating this dangerous state of rebound hypercoagulability.
And the fallout from that rebound can be absolutely catastrophic. We're talking about a new DVT, a life-threatening PE, a clot forming on their central line that they need for treatment. Any one of these things can happen, and they immediately drive up the patient's risk of serious complications or even death.
And it doesn't stop there. It creates this whole domino effect of bad outcomes. A new clot means a longer hospital stay. It means we have to escalate them to much higher, riskier therapeutic doses of anticoagulants. Suddenly, the very bleeding risk we were trying to manage is now even higher. One single missed dose can completely derail a patient's recovery.
So I'm going to leave you with this question. Knowing what's at stake, what is one small thing? A check you add to your handoff, a way you talk to your patient about it, a simple reminder for yourself. What is one thing you can change in your practice starting today to make sure this life-saving dose is never, ever missed? Because for your patients, it's everything.